Hello everyone and welcome to my YouTube channel. My name is Thomas and today I'll be discussing genito-urinary disorders in pediatric patients. This topic is very crucial because these disorders significantly impact children's health and they end up affecting their urinary and reproductive system. So early diagnosis and management is key in preventing the long-term complication of these disorders. To begin with, we shall define what a GU or genitourinary disorder is, and this is just a term that is generally used to refer to any disease that will be affecting the urinary and the genital organs. According to the World Health Organization classification of diseases, the 11th revision, the urinary system encompasses conditions related to the kidneys, the urinary tract, and the reproductive organs. For instance, the WHO includes kidney failure under genitourinary diseases, noting that it can be caused by diabetes or blood, the hypertension or increased blood pressure. Additionally, World Health Organization recognizes that certain infections such as trichomonas could also affect the uh, urogenital tract. When you look at the burden of the pediatric genitourinary disorders, you find that these disorders have a significant health concern worldwide, contributing to morbidity and chronic kidney disease mortality if they are not diagnosed and treated early. So globally, common genitourinary conditions include urinary tract infections, congenital anomalies like hypospadias, vesicoureteral reflux. We also have nephrotic syndrome and Wilms tumor as some of the conditions. Generally, there is limited access to specialized care and delayed diagnosis, which normally leads to complications like end-stage renal disease. In Africa, infectious causes such as the post-streptococcal glomerulonephritis, hemolytic uremic syndrome are very prevalent due to poor sanitation, malnutrition, and limited health care access. In Kenya, to be particular, the burden is high due to the frequent UTIs that are linked to poor hygiene and antibiotic resistance. We also have late diagnosis of conditions like the Wilms tumor or the nephroblastomas and congenital anomalies. So there are high rates of the post-streptococcal glomerulonephritis and the hemolytic uremic syndrome. This one causes kidney failure. So limited access to pediatric nephrology services, especially in rural areas, normally exacerbate the problem. So ladies and gents, during our presentation that we're going to have today, we are going to look at several disorders and we have classified them into 6 categories. We have the congenital disorders, which will include conditions like hypospadia, epispadias. We're also looking at the second group of urinary tract infection and the vesicoureteral reflux, nephrotic syndrome and glomerulonephritis, urological emergencies like testicular torsion. I think most of you are familiar with that. Do you know of any other urological emergency that you know? Yes, the posterior urethral valves, along with testicular torsion and the Wilms tumor that we have mentioned, will be classified under the urological emergencies. Then we'll also look at another condition that is we have categorized as nocturnal enuresis, and lastly the hemolytic uremic syndrome. So ladies and gents, we have tried to list all the disorders, the most prevalent one, and this is what we are supposed to be discussing. It could be a congenital urinary tract infection grouped under nephrotic syndrome and glomerulonephritis, urological emergencies, nocturnal enuresis, or hemolytic uremic syndrome, right? Okay, now allow us now to look at some of the individual conditions now, starting with the hypospadia, right? Hypospadia. So this is a congenital condition where the urethral opening is located on the underside. The underside is usually the ventral side, right? The ventral side of the penis rather than at the tip. So the severity of this condition normally varies. The opening may be near the glans, in the mid shaft, or even at the perineum in severe cases. I think we have tried to highlight it on our right side of the presentation. And hypospadias are associated with the coda. Coda is normally the downward curvature of the penis. Treatment involves the surgical correction, and which is normally performed in infancy. Most cases of hypospadia need surgery to correct the defect. Researchers are estimating that about 1 in every 150 boys has hypospadia at birth, especially in the developed nation, that is the United States. So we need to emphasize the different types. We have the antral, where we have the antral where the opening is near the glans penis, and this one is the most common classification of hypospadia. Then we also have the middle, that is the shaft opening along the mid-penile shaft. Then lastly the posterior, the proximal, where the opening near the scrotal or the perineum. So we have indicated that this is the most severe form of hypospadia. So ladies and gentlemen, which one is the most common classification of hypospadia? Anterior, or the distal one, right? Thank you so much. So what are some of the symptoms of hypospadia? Well, hypospadia does not usually cause physical pain or block urination. So in children, hypospadia can cause problems with toileting training. In adults, untreated hypospadia can cause difficulty getting an erection and consequently infertility. So how do you diagnose this condition? Hypospadia is usually diagnosed during a physical exam after birth. So after birth, you have to perform your physical examination, and one of the indication is to rule out congenital abnormalities. And one of the congenital abnormalities, you are saying it could be hypospadia or epispadia. So the surgery to repair hypospadia is normally referred to as hypospadia repair. A common technique used for this procedure is what we refer to as the metal advancement and the glans plasty, which involves repositioning the urethral opening to the tip of the penis by manipulating the existing tissues. So the primary goal for the surgery is to reconstruct the urethra to its proper position on the tip of the penis. So depending on the location of the hypospadia, different surgical techniques may be performed. This surgery is typically performed in early childhood, and we have indicated it should be performed between the 3rd and the 18th month. In short, in infancy. And this is just to optimize surgical outcomes and allow normal development. As you perform the surgery, their goal is just to ensure proper urination, proper urinary function, and now you have a straight penis rather than a curved one. Although in some quarters we have had people preferring curved, we have had such talks, but we have to know as nurses that curvature is more associated with hypospadias. Some of the complications associated with hypospadias include most complications could occur within the first few months after surgery. Fistulas, strictures may not be detected for years after surgery. Most problems can easily be fixed with surgery after the tissues have been healed. Other complications could be that hypospadia will be associated with undescended testes or inguinal hernia. So that marks the end of the presentation on hypospadia. ladies and gents, I have attached a free quiz on hypospadia. You could attempt that free quiz in the description section just to test your understanding of the presentation on hypospadia. Next, we look at another congenital abnormality, that is the Epispadia. And on our right, you can see the diagram and notice the difference between hypospadia and epispadia. First of all, look at the normal, so that we have the opening at the tip, and then we have now the hypospadia, the underside or the ventral side. Then the epispadia, the opening is on the back, right? So these are rare defect where the urethral opening is on the upper or the dorsal surface of the penis. In females, the urethra may be abnormally located or split. Epispadias is often associated with bladder exstrophy, where this is a condition where the bladder is exposed outside the body. We'll also be looking at this condition later. Surgery is needed to reconstruct the urethra and improve the function. So the common causes will include the imbalances in fetal hormones, which can lead to improper urethral formation. We also have genetic mutation, which can affect urethral development. A family history of epispadia or related factors increase the risk, and also malformations in the pelvic organs can interfere with normal urethral formation. So we have a hormone, we refer to it as testosterone, and this testosterone is essential for male genital development. So when you have low levels or insensitivity, it can lead to abnormal urethral formation. We also have another one, the dihydrotestosterone. These are more potent form of testosterone and is critical for urethral and penile development. Deficiency can lead and can dispose someone to epispadia. Anti-Mullerian hormone, this normally helps male reproductive tract differentiation. So imbalances can contribute to these abnormalities. We also have a hormone and a gene that is the Wilms tumor 1. This one regulates kidney and development, so mutation could also be linked to this. We also have the sex determining region. This one controls male differentiation. Defects could also cause abnormal urethral placement. These other ones are important for limb and genital tract development, so mutation can also lead to malformations. And lastly, fibroblast growth receptor 2 is involved in mesoderm tissue development, including the urethra. So mutation can also contribute to epispadia. So we have several symptoms associated that the patient with this condition can present. Usually urine will exit the body from the abnormal location. So was the treatment surgical? They are surgically corrected by pediatric urologists. We have risks. Of course, all surgery carries a small risk of bleeding, infection, and complication from anesthetic. There is a risk that the wound will not heal properly or open up again, and there is a risk of kidney damage in children with bladder exstrophy. Ladies and gents, that's the end of Epispadia. There is also a touched quiz on Epispadias. You can also attempt to test your understanding of the condition. Another congenital abnormality are the phimosis and the paraphimosis. These are conditions that affect foreskin of the penis. Phimosis is the inability to retract this foreskin. You can also be on the right side of our presentation. The first diagram is the normal where we have the glands and the foreskin, and you can see the glands is exposed. But in the second one, that is phimosis, foreskin cannot be pulled back to expose the glands. So it is hard to expose the glands in phimosis. So what happens to paraphimosis? Paraphimosis now is when the foreskin is trapped in a retracted position. So look at the third diagram. Remember the first one is normal, the glands is easily exposed. The second one, the glands cannot be exposed. right? Because the foreskin is so tight, it can't be pulled back to expose. Now in this case, we have pulled back, but now it cannot be retracted, okay? It cannot be pulled forward to cover the glands. So this one is now a paraphimosis, right? The paraphimosis. The foreskin doesn't loosen over time, forcing the skin to retract before it's ready. Phimosis mostly is caused by some times infections, and you need to know that. So all are the most common disorders. We have the Hypospadia, Epispadia, Phimosis, and paraphimosis. I request you guys to look at the free quizzes that is going to test your knowledge on those four conditions that we have looked at. So let's proceed to Cryptorchidism. Cryptorchidism is also a congenital abnormality, right? Congenital abnormality. Commonly it's referred to as undescended testes, right? Common childhood condition where the boy's testicles are not in their usual place in the scrotum. It is estimated that about 1 in every 25 boys are born with undescended testes. So this one is another reason why we have to perform assessment to check that the testes have descended, because it's a common problem. In most cases, no treatment is necessary as the testicles will usually move down into the scrotum naturally during the first 3 to 6 months. So when a child has undescended testes and they are coming for immunization from the 3rd to the 6th month, that's when you need to confirm that they have descended, right? But around 1 in 100 testicles will stay undescended unless treated. The medical term for having 1 or 2 undescended testes is referred to as, it could be uni or bilateral cryptorchidism, right? Undescended testicles are usually detected during the newborn physical examination carried out soon after birth, or just during a routine checkup at the 6th or the 8th week. Remember, in Kenya, at 6 weeks, you are receiving the first dosages. Undescended testicles aren't painful, so you don't expect the child to be crying, right? So during pregnancy, testicles normally form inside a baby's boy tummy before slowly moving down into the scrotum about a month or 2 months before birth. It's not known exactly why some boys are born with undescended testicles. Most boys with this condition are otherwise completely healthy. So being born prematurely, that is before the 37th week of pregnancy, and having a low birth weight, a family history of undescended testes, might increase the chances of a boy being born with this condition. If the testicles haven't descended by 6 months, they are very unlikely to do so. So treatment will usually be recommended. So remember, at 6 months, what are you giving the child in Kenya? You're giving the vitamin A 100,000 international units, right? So that is what you're supposed to confirm, that actually the testes have now descended. And this is because boys are with untreated descended testicles have fertility issues, so they are likely to suffer from infertility in later life, and an increased risk for developing testicular cancer. Treatment will usually involve an operation, and this operation is what is referred to as orchidopexy. Orchidopexy is used to move the testicles into the correct position inside the scrotum. This is a relatively straightforward operation with good success rate. Surgery is ideally carried out before 12 months of age. If undescended testicles are treated at an early age, the risk of fertility problems and testicular cancer are reduced. Ladies and gentlemen, we are done with the cryptorchidism, undescended testes. Kindly use the link to attempt the free quiz to test your knowledge on that condition. The next condition for us here is the vesicoureteral. urethral reflux disease. So this one is an abnormal backward flow of urine from the bladder where urine is supposed to be stored into the ureters and sometimes into the kidneys. So there's backflow of urine back to the kidneys. So normally the uterovesical junction, that is where the ureters enter the bladder, would be preventing urine backflow with a valve-like mechanism. But in vesicoureteral reflux, this mechanism is defective, leading to recurrent urinary tract infection and kidney damage. Severe cases can lead to hydronephrosis, that is swelling of the kidneys, and chronic kidney disease. We have different types of vesicoureteral reflux. First, the primary vesicoureteral reflux, which is a congenital defect in the uterovesical junction, often resolving as the child grows. Secondary results from bladder dysfunction, e.g. could be the neurogenic bladder, posterior urethral valves, or obstruction, e.g. The UTI is causing the increased bladder pressure. This disease is also graded on a scale of 1 to 5. That is a severity scale. So that grade 1, the reflux into the ureter there is reflux to the ureters without their dilatation. Grade 2, there is reflux to the ureter and the renal pelvis without dilatation. Grade 3, we have mild dilatation of the ureter and the renal pelvis. Grade 4, we have mild dilatation with loss of renal function. And grade 5 is the most severe one. There is severe dilatation with twisting of the ureters and renal damage. Remember, twisting of the ureters is what we refer to as toticity, right? For that. Recurrent febrile UTIs will often be the first sign in children and infants of a child with vesicoureteral reflux disease. There will also be dysuria. This is painful urination, frequency, urgency, and foul-smelling urine. The child could also experience enuresis. Enuresis is bedwetting. Remember, this is one of the disorders that we shall be looking at towards the end of this presentation. So failure to thrive, irritability in infants, hypertension in some severe cases. Remember that the kidney has been damaged in this case, so uh, it's going to respond by increasing the renal secretion, which is going to be counterproductive. Again, when the kidney is not working now, it means the waste will not be excreted. So accumulation of waste is also going to predispose the patient to hypertension. Voiding cystourethrogram is the gold standard, and it uses contrast X-ray to visualize the reflux. We can also perform the renal ultrasound, which will identify the hydronephrosis of the kidney scarring. We also have the DMSA scan, which assesses the kidney function and detect scarring. On treatment, we have, it depends with the case. We could have the mild case, moderate case. Like the mild case, that is grade 1 to grade 2. This one may resolve spontaneously as the child grows. We could also use prophylactic antibiotics, so we use low dose to prevent UTI and frequent monitoring using the ultrasound. For the moderate to severe cases, that is from grade 3 to grade 5, we could do endoscopic deflux injection, that is minimally invasive procedure where a bulking agent is injected near the ureter to prevent a reflux. We also do the surgical urethral reimplantation, that is for persistent and severe vesicoureteral reflux. The ureters are repositioned to the bladder to restore function. We also have blood pressure control, especially if hypertension is present. For the nursing consideration, we could prevent UTI complications by teaching proper perineal hygiene, that is wiping from front to back. Also encourage frequent bladder emptying, increase fluid intake to flush out bacteria, monitor for fever, foul-smelling urine, or new incontinence. Post-surgical care, we monitor for urinary retention, hematuria, and pain. You teach the parents catheter care, and you also encourage gradual return to normal activity. Complication of the vesicoureteral reflux, we could have recurrent pyelonephritis, that's recurrent kidney infections, hypertension due to kidney, this is due to kidney scarring, and chronic kidney disease in severe cases. Ladies and gents, that is all about the vesicoureteral reflux disease. You could pause the video and attempt the free quiz on the vesicoureteral reflux disease just to test your understanding of this session. The other condition is the posterior urethral valve. Posterior urethral valve. This is a congenital disorder in boys, and congenital in boys that leads to backflow of urine, resulting in kidney problems. So these are congenital obstruction caused by abnormal membranous tissue in the posterior urethra, leading to urethral outflow obstruction in male infants. This results in bladder distension, vesicoureteral reflux, hydronephrosis, and possible renal failure. The severity of posterior urethral valve determines the extent of the kidney and the bladder damage. In terms of symptoms and diagnosis, we could do, and during the antenatal visits, we could detect it on prenatal ultrasound. We could also look at oligohydramnios, where we have low amniotic fluid levels. This could be due to poor fetal urine output, so it could be a problem with the baby. And one of the most common suspects is the posterior urethral valve disease. Also, we could have distended bladder with thickened walls. Postnatal symptoms, we have poor urinary stream or dribbling urine, recurrent UTIs, sepsis and dehydration, failure to thrive, and respiratory distress due to pulmonary hypoplasia from oligohydramnios. And that's why posterior urethral valve is also classified under urological emergencies in as much as it's a congenital disorder. So we can do ultrasound, will show hydronephrosis and thickened bladder walls. Avoiding cystourethrogram is the gold standard. It detects reflux and presence of obstructing valves in the urethra. Urodynamic studies will assess bladder function, and lastly, serum creatinine electrolytes evaluates the renal function. So notice on our diagram the vesicoureteral reflux disease. I think this one we had looked at it. Treatment of this condition, we can do initial stabilization in units. As we said, this is an emergency, the posterior valve disease. Could do bladder decompression with the urinary catheter to relieve obstruction, IV fluids and electrolyte management if dehydration is present, prophylactic antibiotics to prevent UTIs. Definitive treatment, we do the endoscopic valve ablation. This is the primary treatment. It uses a cystoscope to remove the obstructing tissue. We also have the vesicostomy, which is performed if severe obstruction prevents immediate valve ablation. And we also have the ureterostomy or bladder augmentation in severe cases of bladder dysfunction. The nursing consideration, right? So the pre-op care, we monitor for urinary retention, dehydration, and electrolyte imbalance. We educate parents or the caregivers about the surgical options and long-term prognosis, and then prevent UTIs by proper perineal hygiene and catheter care. In post-op care, we monitor for urinary output. You expect an initial increase in urine volume post-surgery. You assess for infections, hematuria, and signs of urinary tract injury. You educate parents on long-term follow-up. Children with posterior urethral valve are at risk for chronic kidney disease. Complication of posterior urethral valve could have end-stage renal disease if left untreated, bladder dysfunction leading to urinary incontinence, and pulmonary hypoplasia in neonates. And this is normally due to severe oligohydramnios. So, ladies and gents, that is all about the posterior urethral valve. It's a congenital disorder and also a urological emergency. Could pause the video and attempt the free quiz on the posterior urethral valve disease. Remember, this is the disease for the boys. Next condition is urinary tract infection, and this is just an infection of the urinary tract, including the bladder. In the case of the bladder, we refer to it as cystitis, urethra, urethritis, and the kidney pyelonephritis, right? So it occurs due to bacterial invasion. Most common suspect is usually the Escherichia coli from the gastrointestinal tract. In children, UTIs are often associated with urinary stasis, vesicoureteral reflux, or congenital anomalies of the urinary tract. So we have some risk factors that predisposes children to UTIs. Number one, we have the vesicoureteral reflux, which increases the risk of recurrent UTIs, or posterior urethral valve, which causes urine obstruction. We also have neurogenic bladder, like in the case of spina bifida. This one normally leads to incomplete bladder empty. So those are some of the anatomical risk factors. In behavioral and hygienic factors, we could talk of poor perineal hygiene, especially in the ladies or the girls, and bubble baths. Bubble baths normally irritate the urethra, delayed toileting training, or infrequent voiding. For medical factors, we have the uncircumcised males. These ones, they have a higher risk in infancy, and immunosuppression, like someone having diabetes, chronic illness, constipation can compress the bladder and cause urinary retention. So we have non-specific symptoms like fever, irritability, poor feeding, vomiting, and diarrhea in infants. Could also have strong smelling urine or failure to thrive. In older children, that is more than 2 years, this one could have painful urination, or abdominal or suprapubic pain, cloudy, foul-smelling urine, or fever with pyelonephritis if you have. So pyelonephritic symptoms will include high fever, chills, flank pain, vomiting, dehydration, malaise, and costovertebral angle tenderness, that is severe tetanus. In terms of diagnosis, you could do urine collection methods like the clean catch midstream urine. This one is preferred for toilet-trained children. Catheterized specimen, this is preferred in infants and young children. And suprapubic aspiration, this is the gold standard for neonates, although it is rarely used. Laboratory tests, you could do urinalysis. So you look at leukocyte extras, which will indicate white blood cells. Increasing white blood cells could show the infection. Nitrates will suggest bacterial invasion, mainly the gram-negative bacteria. So you are able to see the nitrates. For the urine culture, you look at more than 1,000 in a clean cut specimen will confirm that there is a UTI, right? More than 50,000 in catheterized specimen could also support a diagnosis. Renal ultrasound could be indicated in recurrent UTIs or infants with febrile UTIs to check for any anomalies. The voiding cystourethrogram is done in recurrent UTIs or suspected VURs. In terms of treatment, we do the antibiotic therapy, where the first line antibiotics that is oral for mild cases. To do the trimethoprim sulfamethoxazine, that is Septrin, amoxyl clavulet, that is the augmentin, or cephalosporins, like the cefixime and cevictidine, IV antibiotics for severe or pyelonephritic cases like ceftriaxone, cefoxitisone, and gentamicin. We also have supportive care where you need to increase fluid intake to flush out the bacteria, use acetaminophen for fever and pain relief, and you encourage frequent urination to prevent stasis. Hospitalization criteria, you look at the toxic appearance, dehydration, ability to take fluids, you have to hospitalize. Children with severe pyelonephritis hospitalized. Neonates who are less than 2 months, they have to be hospitalized because they have special needs to be attended. So for the nursing consideration for pediatric criteria, we have acute management. So you have to monitor urine output and hydration status, encourage frequent voiding and proper perineal hygiene, educate parents and caregivers on proper antibiotic use, that is, they need to complete the full dose. Advice on avoiding bubble baths and use loose cotton underwear. For the long-term prevention strategies, you encourage double voiding, that is urinating twice, first to fully empty so that you are able to fully empty the blood. You treat constipation to prevent urinary retention and you monitor for recurrent infection and kidney damage. Complications of untreated UTI could lead to pyelonephritis, which could cause kidney scarring, and this could predispose the patient to chronic kidney disease. Hypertension could be due to renal scarring and sepsis in infants, especially those who are less than 2 months old. Ladies and gentlemen, that's all about urinary tract infection in pediatric population. I'll advise that you pause the video and attempt the free quiz on urinary tract infection in children. Next, we move now to another one. And this one, we are looking at nephrotic diseases. So we have nephrotic syndrome and glomerulonephritis. So first, we start with nephrotic syndrome. This is a condition that can occur as a result of glomerulonephritis, a family of kidney diseases that damages the glomeruli. So glomeruli are tiny filters in the kidneys that separate waste from blood. When the glomeruli are damaged, they allow too much protein to leak into urine. So the patient is going to be losing protein, close to 3.5 grams of proteins excreted per day. What are the symptoms of nephrotic syndrome? So we have protein in urine, which can make it appear frothy or dark in color. We also have fluid retention, which can cause swelling of the hands, the feet, the face, and abdomen. We have high BP can occur due to the low levels of protein in the body, in the blood. Then we have high cholesterol can occur due to low levels of protein again in the blood. Other symptoms include joint pain, fever, rash, shortness of breath, stomach pain, and tiredness. So glomerular diseases such as the focal and the segmental glomerulosclerosis, immunoglobulin A glomerulonephritis, and membranoproliferative and glomerulonephritis can be the causes, along with congenital infection, diabetes, SLE, neoplasia, and certain drug use can predispose and cause this disease. Nephrotic syndrome is a kidney disorder characterized by massive protein loss in urine. That is proteinuria. We've talked of more than 3.5 grams per day, right? And when this happens, it leads to edema, hypoglobinemia, and hyperlipidemia, right? Remember, hypoglobinemia will lead to water and sodium retention, which causes edema. Hyperlipidemia and lipiduria results from the loss of immunoglobulin and coagulants in blood, right? So this disease occurs due to increased permeability of the glomerular basement membrane, allowing protein leakage. The hallmark feature is generalized edema. Generalized edema is commonly referred to as anasaka, and this starting with the periorbital or a periorbital swelling. In terms of tests for the nephrotic syndrome, we could do urinalysis, which will show massive proteinuria, more than 3.5 grams per day. So we could also look at urine protein, that's 24 urine, which will going to confirm protein loss. Spot urine protein or creatinine ratio, which will be elevated more than 2. Blood test, you're going to have low serum albumin, right? So serum albumin less than 2.5 grams per deciliter, elevated cholesterol and triglycerides, normal or mildly elevated BNU and creatinine unless in late stage disease. Other tests include renal biopsy, which is only done if the child is steroid resistant or has atypical features. In terms of treatment, we have the first line treatment. So the first line treatment for nephrotic syndrome are the corticosteroids. So probably give the prednisone 2 milligrams per kg per day for 4 to 6 weeks. Then you taper over 6 months. Response to steroids is crucial. So steroid sensitive nephrotic syndrome will improve with prednisolone, and steroid resistant nephrotic syndrome, this one requires biopsy and second line therapy. Additional medication for severe or resistant cases, we have the use of immunosuppressants like the cyclophosphamide, tacrolimus, and cyclosporine. We also have the use of diuretics like furosemide, the Lasix, to manage severe edema. Use of angiotensin converting enzyme inhibitors like the prils, enalapril, lisinopril. This is just to reduce proteinuria. And we also have the use of the HMG-CoR inhibitors, the statins, if hyperlipidemia is severe. Supportive care will involve low sodium diet to reduce fluid retention, adequate protein intake but not excessive, strict monitoring of fluid balance and weight. Dietary and lifestyle changes include low sodium, which you have said this one is going to control edema. Adequate protein will also help to prevent malnutrition, but you need to avoid excessive protein, which can worsen the kidney damage. Fluid management. So you need to have balanced fluid intake to prevent dehydration, at the same time overload. So you have to balance between those two. Management of complications involve, number one, you have to prevent infections like we could use the pneumococcal and the flu vaccines, which have been recommended for this. Managing high cholesterol. So statins may be used if hyperlipidemia is so severe. And then you have to do regular checkups to assess the disease progression. For dialysis and kidney transplant, we have for severe or end-stage nephrotic syndrome or dialysis or kidney transplantation, DASA may be necessary. In terms of nursing consideration, we have what we call acute management and long-term care and prevention. Starting with the acute one, you have to monitor for signs of infection. That could be nephrotic. As you know, nephrotic syndrome normally increases risk for the infection. Monitor for daily weight, urine output, and edema, and educate the parents, the caregiver, on the steroid adherence and side effects like the mood changes, the growth suppression. Also prevent skin breakdown due to severe edema. In long-term care and prevention, you monitor for relapses. This is very common in childhood. Teach caregivers about early signs of edema and when to seek medical attention. Emphasize vaccination. So you need to avoid live vaccines during steroid therapy. Complications of nephrotic syndrome. We could have infection like peritonitis, pneumonia, and cellulitis. And this is all due to immune suppression. Thrombosis. This is deep venous thrombosis, pulmonary embolism, all because of the hypercoagulable state, right? The hypercoagulable state will predispose the patient to such disorders. We also have acute kidney injury, abbreviated as AC, and this is because of the severe fluid shift, right? The severe fluid shift might predispose the patient to that. Ladies and gentlemen, that's all about the nephrotic syndrome. I'll advise that you pause the video and attempt the free quiz on the nephrotic syndrome. So let's proceed to another sister condition to it, and that is glomerulonephritis. Glomerulonephritis. That is the inflammation of the glomeruli. And when it is inflamed, it leads to impaired renal function. It causes hematuria, proteinuria, hypertension, and edema. And all this is due to changes in the glomerular capillary walls. Glomerulonephritis can be acute, that is sudden in onset, often post an infection, or it could be chronic. So this is progressive kidney damage over some time. In terms of types of glomerulonephritis, we have the first type, we refer to it as the acute post-streptococcal glomerulonephritis. This is the most common in children and occurs between 1 to the 3rd week after a group A streptococcus throat or skin infection. Have immune complexes which deposit in the glomeruli, and that one causes inflammation. The second type of glomerulonephritis is the IgA nephropathy or the Buerger's disease. This is the most common chronic glomerulonephritis in children and leads to recurrent episodes of gross hematuria, often after an upper respiratory infection. The third type is the membranoproliferative glomerulonephritis. This one is associated with immune system disorders such as the systemic lupus erythematosus or the hepatitis and can lead to chronic kidney disease. Lastly, we have the rapidly progressive glomerulonephritis, and this is the severe form leading to acute kidney failure, is associated with the Goodpasture syndrome or the SLE syndrome. In terms of symptoms of glomerulonephritis, we have hematuria, where the patient presents with the tea-colored or cola urine. Proteinuria, this could be range from mild to moderate. Remember, for nephrotic syndrome was severe. Edema, so the patient could present with periorbital edema, which progresses to generalized edema that we are referring to as anasarca, although anasarca is more pronounced in the nephrotic syndrome. Hypertension, so the patient will present with symptoms like headache, blood vision, seizures in some cases. Oliguria, the patient is going to present with decreased urine output, and this is due to kidney dysfunction. Fatigue, fever, malaise, this one result especially from post-streptococcal glomerulonephritis. How is this condition diagnosed? We could do urinalysis. So we look at hematuria. So we're going to have RBC CAS present. Proteinuria, we could have 1 plus, but less than the nephrotic range, right? The nephrotic disease was more severe. Remember, we talked of 3.5 grams per day. For the blood test, could have the elevated serum creatinine and the BNU, which indicates kidney dysfunction. Low complement, the C3 levels, antistrepsin titer, that was confirms that there was a recent streptococcal infections. Serological test for the lupus in autoimmune glomerulonephritis. We could also do imaging and biopsy. So the renal ultrasound will evaluate the kidney size and the structural damage, while the kidney biopsy is done for severe or atypical cases to determine disease type. In terms of treatment and management of glomerulonephritis, we have supportive care. In most cases, they are self-limiting. So we could do the fluid and sodium restriction to control edema and hypertension. Could also use the diuretics like the Lasix for severe edema. Antihypertensives like the calcium channel blocker nifedipine or the angiotensin converting enzyme inhibitor enalapril just to control the blood pressure. Specific treatment based on the cause. So we don't have specific treatment underlying for streptococcal infections, although we do use the penicillin if it is still active, right? If it's still active, you can give penicillin. You also, in this other type, you also may require the angiotensin converting inhibitor, that's like enalapril, sinopril, or a steroid like prednisone. For lupus, you need immunosuppressants like the cyclophosphamide and mycophenolate. The last one requires plasmapheresis and high-dose steroids. We could also do dialysis for severe cases, especially if there is a acute kidney injury and that has progressed to uremia or fluid overload. In terms of nursing consideration, you monitor for fluid balances, so you do daily weights and strict input and output monitoring. You assess for worsening edema and hypertension. You also need to manage hypertension, so you teach parents to monitor BP at home. You educate on low sodium diet to reduce fluid retention. Could also prevent infections. You encourage hand hygiene and prompt treatment of strep infection and avoid live vaccine if the patient is on immunosuppressants. Hypertensive encephalopathy, like the seizures, a stroke, are some of the complications of glomerulonephritis, along with acute kidney injury, CKD, and pulmonary edema from fluid overload. Ladies and gents, that's all about the glomerulonephritis. I suggest you pause the video and attempt the free quiz. The other condition is the congenital hydronephrosis. Congenital hydronephrosis is a condition characterized by dilatation of the kidney due to urine build-up and is normally caused by an obstruction or a reflux in the urinary tract during fetal development. Congenital hydronephrosis is often detected prenatally on ultrasound. Most cases normally resolve spontaneously. However, severe cases can lead to kidney damage if left untreated. We have several causes, so like the uretropelvic junction obstruction, which is the most common cause, blockage where the ureter meets the kidney. We also have the posterior urethral valve in males, of course. This one mainly affects the males, the male infants, and this one will cause bladder outlet obstruction. Uretrovesical junction, this one blockage where the ureter meets the bladder. When looking at the non-obstructive causes, we have the VUR, Vesicoureteral reflux disease, characterized by backflow of urine from the bladder back to the kidney, or the Prune-Bailey syndrome, that's abnormal well muscle deficiency affecting the urinary tract. In terms of symptomatology, prenatally, this condition can be detected on ultrasound. So you could see the unilateral or bilateral kidney dilatation, that's hydronephrosis. Also, we could also have oligohydramnios, low amniotic fluid in severe cases. Postnatally, now we are talking of the newborns or the infants. So they could present with abnormal mass. Those could be due to enlarged kidneys, recurrent UTIs, poor urinary output or difficult urinating, and failure to thrive, irritable if there is severe kidney damage. How do you diagnose prenatally? We could do fetal ultrasound around the 20th week scan. This one can help detect kidney enlargement. Could do amniotic fluid levels. For a severe obstruction, it might lead to low amniotic fluid, that is oligohydramnios. Postnatally, we have the first line test, which is the renal ultrasound. This one identifies the renal or the kidney dilatation and obstruction. Could also do VUR, the voiding cystourethrogram, and this is suspected. It could also detect urine reflux. We have the MRI, the magnetic resonance urography. It could be used in advancing imaging for severe cases, and the diuretic renal scan. This one evaluates kidney functions and drainage. In treatment and management of congenital hydronephrosis, we could do for mild cases where there is no obstruction, but with normal kidney function. This one can resolve spontaneously within 1 to 2 years. But you need to monitor for repeat ultrasounds every 3 to 6 months and also give prophylactic antibiotics to prevent UTIs, although in some cases not all. Moderate to severe cases, that is cases where we have obstruction and a reflux, we could do endoscopic surgery if this is due to posterior urethral valves. Could also do pyeloplasty, this is a surgical correction of urethral pelvic junction, and ureteric reimplantation for severe vesicoureteral reflux disease. Diagnosis or kidney transplant, the rare and end-stage cases. So if severe hydronephrosis leads to kidney disease, you have to perform that. For the nursing, in pre-surgical care, you monitor urine output and signs of urinary retention. You educate parents on UTI prevention and hydration, and explain the need for serial ultrasound to track kidney growth. For post-surgical care, you monitor for infection, hematuria, and catheter blockage. You ensure proper hydration to prevent further kidney stress and educate parents on the signs of the worsening. That could be like fever, vomiting, or lethargy. On our diagram, notice the kidney with hydronephrosis. So the urine is trapped in the kidney or the ureters. That results into dilatation of that ureters and enlargement of the kidney. Complications of untreated hydronephrosis include chronic kidney disease, this progressive loss of kidney, recurrent tract infection due to kidney scarring, reflux nephropathy, and hypertension due to long-term kidney damage. Ladies and gents, that's all about congenital hydronephrosis. Pause the video and attempt the free quiz. So we're going to look at one of the emergency in urological in urology, and this is the Wilms tumor. It's the most common kidney and abdominal cancer in children, right? In children, actually is the most common pediatric renal malignancy, right? Typically occurs in children younger than age 5 and presents mostly affecting between the 3 to 5 years. It has a 5-year survival rate of 92%. It might affect one or both kidneys. So 90% of cases will be related to one kidney, while the 10 will be affecting it will be a bilateral, so that's affecting the right and the left. This disease was named after a physician by the name Dr. Max Wilms. And this condition can also be referred to as nephroblastoma, right? It's a rare cancerous tumor in the kidney that mainly affects children. It's the most common types of kidney cancer in children. In terms of pathophysiology, we have abnormal renal development altering the cellular function responsible for the differentiation of the tubules and the glomerulus. Several tumor suppressor genes appear to be involved, but their exact role in the development of Wilms tumor is unknown. So it develops due to abnormal cell growth in the kidney stemming from genetic mutations that disrupt the normal development of the kidney during embryogenesis, most commonly involving the Wilms tumor 1 gene, leading to formation of a tumor composed of blastemal, epithelial, stromal components. Essentially, it arises from persistent metanephric tissue that fails to differentiate properly during the fetal kidney development, and this results into a cancerous mass within the kidney. Wilms has several stages that indicate how far the tumor has spread. So on the staging, we have stage 1, stage 2, stage 3, stage 4, and stage 5. So Wilms stage 1, this is where the tumor is in one kidney and can be completely removed with surgery. For stage 2, the tumor has spread to nearby tissues such as fat or blood vessels and can still be removed with surgery. For stage 3, the tumor has spread to nearby lymph nodes or other parts of the abdomen and can't be removed with surgery. For stage 5, the tumor has spread to other parts of the body such as lungs, liver, bones, or brain. Stage 5, which is the worst? The tumor is in both kidneys. Each kidney is staged separately from this. So the children's oncology group, that is the staging system, is the one that is most commonly used in the United States to describe the extent of the Wilms tumor. Remember, for the other types of tumors, generally we have the TNM staging, right? That is normally used for most of these solid tumors. But in this case, we are going to use the children oncology group staging system, right? That we have been able to stage from stage 1 to stage 5. The best treatment for a child with Wilms tumor depends on the stage of the tumor. Surgery can remove stage 1 and 2 tumors completely. Stage 3 may require additional treatment such as the chemotherapy because they can't be completely removed. In terms of incidence, we have 650 new cases are diagnosed each year in the United States. Wilms tumor is more likely in females than in males. Wilms tumor is more common in African American and least common in East Asian population. 90% of Wilms tumor are diagnosed before age 6 with a median age of about 3.5 years. Complications, of course, the ones that are treatment related. We have heart failure due to chemotherapy that has been used, bowel obstruction due to chemotherapy, pulmonary dysfunction due to radiation, liver damage due to chemotherapy, and infertility is increased risk in females receiving abdominal radiation. Complications which are tumor related, we have secondary malignancies, hemorrhage, wound infection, metastasis, impaired renal function, and tumor recurrence, that is relapse. Notice that the right kidney has a Wilms tumor in our diagram. So commonly there are no signs or symptoms, but we have abdominal swelling or mass. This is the most presenting symptom. Remember, Wilms tumor presents with painless abdominal mass, hematuria, and hypertension. Right? Abdominal pain. This one is less common, but may occur if the tumor now is large or if there is a rupture of or a rupture or bleeding inside the tumor. That's when you are going to have abdominal pain. Fever can be due to tumor necrosis or secondary infection. Weight loss, low appetite may occur in advanced cases. Nausea and vomiting can be due to tumor compression or digestive organs. Shortness of breath if metastasized to the lungs. Wilms tumor can metastasize to the lungs, causing respiratory symptoms. Physical findings, so you find in most cases abdominal pain in between 30 to 40%, and that means it has really advanced. Hypertension in 25 cases, hematuria in 25 to 12 to 25%. This we also have palpable or visible abdominal mass commonly found initially during routine care, abdominal asymmetry, adventitious breath sound if metastasis occurs, lymphadenopathy, and possible cryptorchidism or hypospadia in children with associated syndrome. Remember, abdominal palpation must be done carefully because the tumor is highly vascular and soft and can easily rupture with excessive handling. If you suspect a patient has Wilms tumor after completing the initial palpation, avoid further palpation. So we could do CBC with differential that will show increased white blood cell count. Urinalysis may reveal hematuria and leukocytes. Liver function tests may be abnormal with metastasis. Creatinine serum may indicate reduced glomerular filtration rate. Coagulation studies are done before surgery. Chromosome analysis may reveal a genetic abnormality. In terms of diagnostic test imaging, ultrasonography of the kidney, perirenal structures, and the abdomen identifies the tumor. The four-field chest radiography is performed to detect lung metastasis. Computed tomography scanning or magnetic resonance imaging of the abdomen and chest identify the tumor and possible metastasis. Treatment, generally we have supportive care, radiation therapy, and surgical removal of the tumor. Remember, radiation therapy is typically for stages 3 and 4. In diet, we just do a well-balanced diet and activity just as tolerated by the child. Treatment, in terms of medication, you can use the chemotherapeutic protocols with such agents as vincristine sulfate, dactinomycin, doxorubicin hydrochloride, cyclophosphamide, and etoposide phosphate. Surgery, we could do nephrectomy, that is simple, partial, or radical, central venous access, diverse insertion. What are some of the priority nursing diagnoses for a child with Wilms tumor, that is the nephroblastomas? We could talk of risk for injury related to tumor, rupture, and metastasis, and this is because of the excessive palpation of abdominal mass, which might cause rupture, leading to tumor cell dissemination and worsening prognosis. Number 2, we have acute pain related to tumor growth and surgical intervention. And this could be due to the growing tumor which compresses nearby structures, causing discomfort, post-surgical pain in very common after nephrectomy. Imbalanced nutrition less than body requirements related to poor appetite, nausea, and effects of chemotherapy. As you know, children with Wilms tumor often experience weight loss, nausea, and vomiting, which can lead to malnutrition. Risk for infection related to immunosuppressions from chemotherapy, surgical intervention. We all know that chemotherapy weakens the immune system, and this will increase susceptibility to infection. Surgical wounds are also at risk. Fear and anxiety, that could be for the child or the family or the caregiver, and this is related to cancer diagnosis, treatment, and prognosis. A cancer diagnosis in a child is distressing both for the child and for the family, and this one requires emotional and psychological support. So in terms of nursing consideration for a child with Wilms tumor, you need to administer prescribed medications and monitor their effect. Avoid abdominal palpation, encourage verbalization of feelings and fears. This will allow time for the child and family to cope with the disorder and the prognosis. Also need to assess the child levels of pain utilizing an age-appropriate pain ratings tool. You also provide comfort measures as appropriate, provide adequate hydration and nutrition after a well-balanced diet with appropriate food choices and snacks. Weigh the child daily using the same scale at the same time and the same day with the child wearing the same amount of clothing. Monitor and document fluid input and output and urine output. Anticipate the need for insertion of central venous access device for chemotherapy administration. Prepare the child and family for insertion and prepare central venous access site care and also maintain patterns. Institute safety and infection control precaution, cluster nursing activities to minimize energy expenditure, provide frequent uninterrupted rest periods, encourage the use of energy conservation measures. Provide care measures to address nausea, vomiting, hair loss, and other adverse reactions to chemotherapeutic agents. Prepare the child and family physically and psychologically for surgery as appropriate. You have to explain preoperative and postoperative procedures and equipment. Obtain laboratory specimens to evaluate renal functions preoperatively and postoperatively as appropriate, and provide post-operative care, including the surgical site care, frequent monitoring of the vital signs, renal function, and pain management. You consult a child's life specialist to provide age-appropriate instruction and support, and collaborate with social services to provide counseling, community services, and support. We have several complications associated with nephroblastoma. Number one, we have tumor rupture. So when this happens, cancer cells will spread and this normally worsens prognosis. So that's why in the room for the child with nephroblastoma, you're supposed to indicate there very well that do not palpate the abdomen, right? Number two is hypertension, and this is due to kidney dysfunction or renin secretion. Number three, we have chronic kidney disease, CKD. This is after nephrectomy, especially in bilateral cases. And secondary malignancies, that's from chemotherapy or radiation. Ladies and gents, that's all about the Wilms tumor or the nephroblastomas. You can pause the video and attempt the free quiz on the Wilms tumor. The next disorder you're going to look at is ambiguous genitalia. This is one of the disorders of the sexual development and is classified under the congenital disorders. Remember, that's what we had mentioned, along with bladder exstrophy. All these are congenital disorders. So to begin with, let's look at ambiguous genitalia. And just from the name, and that's how the condition is, you are not sure of the genitalia. So these are congenital conditions where the external genitalia do not clearly appear male or female. This is very controversial in the era where we have LGBTQ group. Someone will argue, so which will be the declared gender for this particular type of patient. So these conditions normally result from abnormal sexual orientation, differentiation due to hormonal, genetic, and enzymatic defects. It is classified under disorders of sexual development, which include the 46XX, like the female karyotype with masculinization, or the 46XY, the male karyotype with incomplete mascularization, and mixed gonadal diagenesis. Remember, disorders of sexual development are conditions where a person's reproductive organs and the genitalia are mismatched at birth. All right. So we have several causes of ambiguous genitalia. We could have the 46 chromosome XX, where this is the genetic female with mascularization. So we have the congenital adrenal hyperplasia as the most common cause. So we have deficiency of the 21 hydroxylase enzyme in 90% cases. So these cases we are going to have excess androgen, and excess androgens are going to cause a large clitoris and fused labia. And when you look at the chromosomal component, we have 46 and is XX. You expect a female. But some of these cases we have congenital adrenal hyperplasia, and this is going to lead to deficiency of the 21 hydroxylase deficiency or enzyme. So this condition will lead to excessive androgen. You know, androgens are more associated with the male. So when this happens to this 46XX, it will cause the virilization, which is characterized by a large clitoris, fused labia, that will make the genitalia to be ambiguous, right? We also have salt wasting, which can lead to life-threatening adrenal crisis. For the 46XY, that is genetic male with incomplete virilization. So 46XY, you expect this one to be a male. But now they could be experiencing androgen insensitivity. So that's what we are referring to, androgen insensitivity syndrome. This will lead to complete AIs, so that testes will be present, but external genitalia appear female. Or we could have a partial AIC where we are going to have varying degrees of under-virilization. 46XY genetic male with incomplete virilization could also be as a result of 5-alpha reductase deficiency. This leads to inability to convert testosterone to hydrotestosterone, and this leads to under-muscularized male genitalia. Another cause could be due to Leydig cell hypoplasia, which results in defective testicular hormone production. The third subtype or cause of ambiguous genitalia could be mixed gonadal digenesis. This could be 45X or 46XY monocyzing. So that includes a combination of testicular and ovarian tissues with ambiguous external genitalia. We have tunnel-like features, so we have short stature with streak gonads. So in the newborn, ambiguous genitalia could present as enlarged clitoris, micropenis, fused labia, and undescended testes. Right? Which have bilateral inguinal masses, which might contain testes in eyes, abnormal or surgical scrotal developments. That could present in the newborn period. In the childhood and puberty, we could have delayed or absent puberty, primary amenorrhea in females, and lack of secondary sexual characteristics. In severe cases, like the congenital adrenal hyperplasia with salt wasting, patients could present with dehydration, hypotension, and renal imbalances, hyponatremia, hyperkalemia, and metabolic acidosis. Notice the ambiguous genitalia. We have intersexual gonal testes, labia majora, hypospadias genital tubercle, and then intra-abdominal dysplastic gonads. It is ambiguous genitalia. So how frequent is ambiguous genitalia in your facility? Please share with us. We want also to understand how prevalent this condition is, especially those who are working in the labor department, right? Maternity units, labor sections. We could also diagnose now this condition using either hormonal and biochemical tests and genetic and imaging studies. So hormonal, we could do serum 17 progesterone. You find it will be elevated in congenital adrenal hyperplasia. Testosterone levels, you assess for androgen production. So of course testosterone will be reduced, right, will be reduced in the genetic male with incomplete virilization. We also look at electrolytes, so hyponatremia, hyperkalemia in salt wasting congenital adrenal hyperplasia. Karyotyping, which determines XX or XY or monocyism, and we expect XX to be female, XY to be male, right? Pelvic ultrasound evaluates presence of uterus, ovaries, or testes. Adrenal CT scan will identify adrenal hyperplasia in CAH. Treatment for congenital adrenal hyperplasia, you do hydrocortisone, cortisol replacement, fludrocortisone for salt wasting, IV fluid and electrolyte for adrenal crisis, and surgical correction for velarized female genitalia, although this is optional. Adrenal insensitivity syndrome. We could do gonadectomy if testes are undescended to prevent malignancy, and also estrogen therapy for puberty induction in complete age. For the 5-alpha reductase deficiency, we could do testosterone therapy for maxillization, gender assignment based on family preference and medical evaluation. Surgical management, if necessary, you could do genital restructive surgery based on functional and psychological outcomes. We need to delay surgery until the child can participate in gender identity decision, although this is a controversial topic to say. So educate the parents about disorders of sexual nature and also the diagnostic process, assess emotional distress and provide psychosocial support, involve multidisciplinary team, endocrinologists, geneticists, psychologists, urologists. You monitor the child puberty, development, and hormonal therapy adherence, support the gender identity concerns and psychosocial well-being, and educate on fertility options and reproductive health. Right? Remember, do not appear completely male or female. Right? They are just there. That is the problem with our patients. Complications of untreated disorders of sexual could include infertility depending on the underlying condition, or increased risk of gonadal tumors, especially in the case of undescended testes, and lastly, psychosocial stress, distress, and gender identity issues. Ladies and gents, that's all about ambiguous genitalia. Kindly pause the video and attempt that free quiz. The next condition is the bladder exstrophy, and I think this one we mentioned it when you are looking at Epispadias. I hope you remember that, and that's why this condition can also be classified as a congenital disorder, right? Congenital disorder. So these are rare congenital anomaly, and here you find that the bladder and parts of the urinary tract are exposed outside the body due to failure in the midline closure during fetal development. It is a spectrum of conditions affecting the bladder, urethra, and external genitalia, and it's more common in males than females. In fact, the ratio is about 3-1, all right? For every 3 males, we have 1 female. So bladder exstrophy, of course, we have the types of bladder exstrophy. The first one, we have bladder exstrophy. That is the most severe form, where the bladder is open and exposed outside the body. The bladder mucosa is visible, urine continuously leaks, pubic bones are widely separated. Epispadia, that is, could be isolated or with exstrophy. This is incomplete urethral formation leading to abnormal urethral opening. So for the males, we could have urethral bladder on the dorsal, that is on the top side of the penis. For the urethra, urethral opening is too wide, making often extending to the bladder neck. The third subtype is the cloacal exstrophy. This is the most severe form, right? The most severe form. So we have the bladder exstrophy plus omphalocele plus imperforate anus and spinal anomalies. abdominal organs may be partially exposed. This is often associated with other conditions like the melanoingocele, the subtype of the spina bifida. This condition is caused by defective cloacal membrane development during fetal growth or failure of the midline mesoderm migration leading to abnormal bladder and genital development, or genetic factors which normally leads to increased risk which are normally increased. The risk is increased in families with a history of this condition. Environmental factors possibly could be linked to teratogens, uh, folic acid deficiency, or maternal smoking. In terms of symptoms for the bladder exstrophy, the bladder is exposed outside the body. There's continuous urine leakage and widened pubic bones, that is pubic diastasis. We also have umbilical hernia or omphalocele in severe cases. For the epispadia, abnormal urethral opening on the dorsal side, and for the females, we'll have wide urethral opening in females, right? Yes. And then urinary incontinence or dribbling could also be seen. Short, broad, upward curving for the epispadia, right? Epispadia, hypospadia, right? Cloacal exstrophy, of course, you've said is the most severe form. So here the bladder, intestines, and reproductive organs are exposed. Patient could also present with other spinal abnormalities like spina bifida or scoliosis, imperforate anus, right? No anal opening. In terms of diagnosis, prenatal diagnosis often in severe cases. So like we can do a fetal ultrasound between the 18th to 20th week, where we'll see no bladder filling in repeated scans, low set umbilicus, abnormal genitalia, and widened spaced pubic bones. MRI or the 3D ultrasounds has confirmed the diagnosis. Postnatally, we have clear defect at birth through the examinations, so that you can see the bladder, and you can also diagnose the epispadia. We also need to evaluate pubic diastasis as skeletal abnormalities. It also assess renal function and ureter abnormalities by the use of the ultrasound. Surgical correction is the main treatment. You close the bladder, restore urinary function, and restructure the genitalia. So we do the stages of surgery. We do it in stages. We have the bladder closure in the neonatal period, that is within the first 48 hours of life. Then we do epispadia repair. This will help restore urethral function, that is between the 6th to the 12th month. And then finally we do now the bladder neck reconstruction around 4 to 5 years of age. So this will help improve urinary continence. We also have urinary diversion for the severe cases. If the bladder function is poor, a continent urinary diversion, that is the mitral fan off procedure, will be done. Some cases require urinary catheterization for life. Ongoing urologic and orthopedic management, you monitor for kidney damage, infections, and bladder, and orthopedic surgery may be needed for pelvic bone abnormalities. So keep exposed bladder covered with sterile, moist dressing, prevent infection, strict hygiene, prophylactic antibiotics, assess fluid and electrolyte balance, educate parents about staged surgeries and long-term management. For post-op, monitor for infection, wound healing, and urine output. Pain management, bladder closure is a major surgery. Encourage early mobilization to prevent complications and teach the caregivers about catheter care and long-term follow-up. Complications associated here, we have urinary incontinence. Most children will require lifelong bladder management. The others we have the recurrent UTIs and kidney damage, pelvic bone abnormalities, difficult walking if not corrected, then infertility, especially in severe epispadia cases. Right. I hope you can be able to see our patient with the scrotums displaced downward, penis with epispadia and inverted bladder, right? So with early surgical correction, children have near to normal urinary function. Continence may require additional surgeries or lifelong catheterization. Fertility is often affected in severe case. I think that's what we had indicated. Ladies and gentlemen, that's all about bladder exstrophy epispadia complex, big condition. These are congenital disorder. You pause the video and attempt the free quiz on that. The other short condition now we have inguinal hernias, and inguinal hernia is a protrusion of abdominal contents that could the bowel, omentum, or other structures through a weak point in the inguinal region. So you can see the inguinal hernia on our diagram is a more common surgical condition in infants and children, particularly in preterm male infants. So types of inguinal hernia, we have indirect inguinal hernia and direct inguinal hernia. So the indirect is the most common type in children. It occurs due to failure of the process vaginosis to close during fetal development. Abdominal contents protrude through the internal inguinal ring and may extend to the scrotum in males. It is more common in preterm infants and males. For the direct inguinal hernia, this is rare in children. It's due to weakness in the abdominal wall rather than persistent processus vaginalis. It protrudes directly through the abdominal wall in inguinal region and is more common in adults than children. So this condition, inguinal hernia, is more common in males. So the ratio is about 5:1. And the risk increases with the prematurity because of the processus vaginalis not closing. Family history of hernia is also a risk factor. There's also increased abdominal pressure, like a child who is constantly crying, coughing, and straining can lead to hernia. Associated conditions. So we could have cryptorchidism, cystic fibrosis, and connective tissue disorders. Symptoms of a reducible inguinal hernia include you have soft, painless swelling in the groin or scrotum, right? Notice our inguinal hernia on our diagram. We have labeled painted red. You can be able to see. More noticeable during crying, straining, or standing. Reduces spontaneously with gentle pressure. Symptoms of an incarcerated inguinal hernia, that should be an emergency. The patient presents with firm, tender, and unreducible groin mass, severe pain, irritable and inconsolable crying, vomiting, abdominal distension, and refusal to feed will suggest a bowel obstruction, and erythema over the mass that suggests strangulation and ischemia. Clinical examination. So we have observation of a bulge in the inguinal area during crying or straining. Attempts at reduction. If the mass is reducible, it will confirm that that is a hernia. If non-reducible, you have to suspect incarceration or strangulation. For imaging, if needed, you could do ultrasound. This one is used to if the diagnosis is unclear or to differentiate it from a hydrocele. Abdominal X-ray if the abdominal obstruction is suspected. The management, you do surgical treatment. This is the definitive management. So this is what is referred to as herniorrhaphy, herniatomy. So you could do elective surgery for all inguinal hernias in children since they do not resolve spontaneously. Or you do emergency surgery for incarcerated or strangulated hernias to prevent bowel ischemia. Number 2, you have non-surgical management. This is temporary for reducible hernia only. So we could do manual reduction. Gentle pressure may be attempted while awaiting surgery. Also provide parental education on monitoring for incarcerated or incarceration symptoms that will require emergency operation. Post-operative care, you monitor for pain, swelling, and infections at the surgical site. Encourage early ambulation to prevent complication. Teach the parents to monitor for recurrence or complications, e.g. fever, vomiting, and persistent swelling. Complications of untreated inguinal hernia include incarceration, that is entrapment of the bowel or the omentum causing an obstruction, strangulation, that is loss of blood supply leading to bowel necrosis, and testicular atrophy due to compression of the spermatic cord. So ladies and gents, you need to know the differences between an inguinal hernia and a hydrocele. So we can differentiate it in terms of causes, transimulation, reduction, and resolution. You find that inguinal hernia are caused by persistent process vaginalis with bowel protrusion, while hydrocele are caused by persistent process vaginalis with fluid accumulation. In terms of transimulation, inguinal hernia are negative, so they don't glow, while hydrocele will glow with light. In terms of reduction, inguinal hernia are normally reducible unless incarcerated. Hydrocele are not reducible. Lastly, inguinal hernia will require surgery, so it could be elective or emergency if it is incarcerated. Hydrocele, this one may resolve spontaneously, right? Thank you so much. That marks the end of inguinal hernia in children. Kindly pause the video and attempt the free quiz on inguinal hernia. Next, we have testicular torsion, and testicular torsion is a surgical emergency. It needs urgent address, right? It's a urological emergency where the spermatic cord twists, right? Twists and cuts off blood supply to the testicle. Remember, the spermatic cord consists of the pumpiform venous plexus, the ductus or the vas deferens, the cryptorchidism artery and vein, testicular artery, artery to the vas deferens, the genito-femoral nerve, that is the genital branch, and the lymphatic. So when they twist and turn, it normally cuts off blood supply to those distant parts, and you can appreciate the different types of arteries that will be blocked. It's more common in adolescents, that is between the ages 12 to 18 years, but can occur at any age. Doesn't have to be that. The risk factors, we have the belly clapper deformity, where testicles lack normal attachment to the scrotum, right? Normal attachment to the scrotum, or a case of trauma, exertion, or spontaneous occurrence, or cold exposure leading to cremasteric contraction, right? Notice on our diagram the difference between the normal anatomy and the testicular torsion, right? Testicular torsion. Look at the arrangement of the testicles, right? The arrangement of the testicle is different, and that's what is normally referred to as belly clutter deformity. I also demonstrate it in this slide. Also, you'll be able to see it. Notice on our diagram, normal testicles and the abnormal, right? Like you can see the testis, the egg in belly in the belly clapper deformity, it's more of horizontal, right? It assumes a horizontal lie, right, against the normal lie for the normal testis. Notice that on our diagram, right? So patients are going to present with severe sudden onset unilateral scrotal pain, often at night or very early in the morning. They also present with scrotal swelling or redness. They also present with absent cremasteric reflux. You know, when you strike the inner thighs, of a patient or of a male patient, we are supposed to have testicular elevation, right? But in the case of testicular torsion, we are going to have absent cremasteric reflex. So the testis will fail to elevate when you strike the inner thigh. Patient can also present with nausea and vomiting, and this is due to severe pain and high riding testicles with horizontal lie, right? Horizontal lie, and this one you can be able to see it on our diagram. We could do Doppler ultrasound where we are going to have decreased or absent blood flow to the affected testicles. Physical findings could include absent reflex, pain relief with elevation, right? Pain relief with the elevation, that's the French sign. This is negative in torsion but positive in epididymitis. Notice in my diagram that I have tried to look at this, what we refer to as French sign in this condition. So in French sign, when someone is having an acute agonizing scrotal pain, you're supposed to attempt to elevate the testis. If you elevate the testis and the pain is plus, there's more pain, that is you suspect there is testicular torsion. But if you elevate the testis, the scrotum, and there is pain relief, that means you suspect another disease. This could be acute epididymitis or orchitis, right? Acute. So positive sign suggests epididymitis, while negative sign, that is pain increase or change, suggests testicular torsion. So a positive sign of testicular torsion suggests what? Epididymitis. Thank you so much. So what about the management of testicular torsion, right? We could do surgical detorsion within 6 hours to prevent testicular necrosis. Orchiopexy, this is fixation of testicles, is done bilateral to prevent recurrence. And if non-viable, orchiectomy, that is removal of the testicles, will be performed. Complication, it could lead to testicular infarction, that is loss of infertility on the affected side, and psychological distress. Ladies and gentlemen, that is all about testicular torsion, right? Testicular torsion is a medical emergency. It requires surgical detorsion within 6 hours to prevent testicular loss. So you pause the video and attempt the free quiz on testicular torsion. The second last condition is enuresis, that is nocturnal enuresis, bedwetting, right? Involuntary urination during sleep in children who are more than 5 years old. So enuresis can either be primary enuresis or secondary enuresis. When you talk about primary enuresis, it means this child has never been dry for more than 6 months, right? Secondary enuresis, this is the recurrence after at least 6 months of dryness, right? And this could be due to stress, could be due to infection, or due to a medical condition. So risk factors associated with enuresis could include genetic predisposition, whether there's family history, or there is delayed bladder maturation, there is increased nighttime urine production, low vasopressin levels, small functional bladder capacity, psychological stress, sleep disorders, or the patient could just be having an urinary tract infection. So the patient is going to present with repeated episode of bedwetting at night, nocturia without daytime symptoms if no underlying pathology, and possible social embarrassment or low self-esteem. So we could do history and physical exam to rule out secondary causes like UTI, diabetes, or constipation. Urinalysis, you check for infection and diabetes. So in terms of management, behavioral therapy is the first line treatment of enuresis. So you could do bladder training where you advocate for the scheduled voiding. Enuresis alarms, this is most effective long-term therapy. And you avoid fluids and caffeine before bedtime. Positive reinforcement like rewarding dry nights. Pharmacological treatment, if needed, you could use the desmopressin, which is going to reduce urine production at night, or oxybutynin, which is anticholinergic for bladder overactivity, oxybutynin. Prognosis, most cases resolve spontaneously with age. Ladies and gentlemen, that's all about enuresis, nocturnal enuresis, right? You could pause the video and attempt the free quiz. The last condition is hemolytic uremic syndrome, abbreviated as HUS. This is the magical dysfunction of the endothelium, microangiopathic hemolytic anemia. Serious conditions caused by Shiga toxin producing E. coli, leading to hemolytic anemia, thrombocytopenia, and acute kidney injury. This condition is more common in children who are less than 5 years, right? Less than 5 years of age. And this one normally follows bloody diarrhea. E. coli infection, that is from uncooked beef, contaminated water, and pasteurized dairy, or other infection like Shigella, Salmonella, Streptococcus, pneumoniae. Certain medication, e.g. chemotherapeutic agents, could be some of the risk factors. So Shiga toxin damages endothelial cells, which leads to platelet aggregation and microthrombi formation. Red blood cells get fragmented while passing through blocked vessel, that is microangiopathic hemolytic anemia. Kidneys suffer ischemic injury, so that leads to acute kidney failure. On the clinical features, we have the clinical triad, right? The clinical triad of hemolytic anemia, thrombocytopenia, and acute kidney injury. So hemolytic anemia will patient will present with pallor, fatigue, tachycardia, and jaundice. Thrombocytopenia, patients are going to present with petechiae, the purpura, bruising, bleeding tendency. And acute kidney patient will present with oliguria, hematuria, hypertension, and edema. Other symptoms include bloody diarrhea. This one precedes an infection, irritability, and seizures if severe. So remember, there is generally blood breakdown leading to increased urea, and this results from blood clots. So the kidney is more affected. In terms of diagnosis, CBC, we have reduced hemoglobin, reduced platelets, schistocytes on the blood smear, elevated creatinine and BNU, that's kidney failure, stool culture for E. coli. Management, you avoid antibiotics and antidiarrheals. This may worsen toxin release. You do supportive care, administer IV fluids, blood, transfusions, electrolyte balance, dialysis if severe kidney injury. Prognosis, most children recover, but some may develop chronic kidney disease. So ladies and gents, there are some of the must-know pediatric genitourinary disorders, and this will be very important in preparation for the NCK and the NCLEX examination. So remember, you have to talk about the UTI, all right, the urinary tract infection, the vesicoureteral reflux disease, and the Epidemiology condition, the NS, the HUS, the Cryptorchidism, that's undescended testis, testicular torsion, enuresis, hypospadias, and the Wilms tumor. At least these are the most common conditions that will be tested in the NCLEX, right? So remember, for the NCLEX strip, for the UTI and the VUR, you have to do the hygiene, and you have to do the VUG for the diagnosis. Nephrotic syndrome is differentiated based on proteinuria versus hematuria, right? So proteinuria is more associated with nephrotic syndrome, while the glomerulonephritis, hematuria. Testicular torsion, emergency surgery should be performed within 6 hours, that's what we have indicated, while for enuresis, behavioral therapy is the first line treatment. You can only use desmopressin if it's severe. And for a client in a room with Wilms tumor or nephroblastoma, you have to ensure that you write, do not palpate the abdomen, all right, for that case. Right? Those are some of the main concepts that we have looked at. So in summary, pediatric conditions disorders are diverse but are manageable with early detections and interventions, right? So you have to know how to identify, assess, and identify those conditions. Otherwise, thank you so much for your attention. I will take any question if you have. You could even post it in the chat. I'll be able to attend to it. Thank you so much.